Olá, boa tarde, bom dia, boa noite, dependendo da hora que você estiver assistindo. Estou muito feliz de estar aqui. Hoje a nossa conversa é com a doutora Lara Briden, que é autora do livro Que Nunca Te Contaram sobre o Seu Ciclo Menstrual, que a gente publicou na Bambual Editora há mais ou menos 2 anos, e a gente finalmente está conseguindo realizar esse encontro com a doutora Lara. Esse encontro é o ápice, vamos dizer assim, do grupo de estudos que aconteceu durante 12 encontros, 12 semanas, estudamos um capítulo por encontro. Tivemos a presença de profissionais de saúde, médicas, enfermeiras, pesquisadoras, psicólogos, e foi muito rico, a gente está muito feliz. Então, essas mulheres que estão aqui no Zoom com a gente são mulheres que participaram desses encontros ou que chegaram agora e estão curiosos também para saber um pouco mais, para saber diretamente da doutora Lara sobre esse livro, né, que é best-seller mundial, que, enfim, que ensina efetivamente a mulher a entender o seu corpo. Então, a gente vai ter aqui a participação da Ana Miller, fazendo a facilitação, a conversa com a doutora Lara. A gente vai ter a Fernanda Rocha fazendo a interpretação em português para a gente. E, Ana, a bola está com você, doutora Lara. Gratidão imensa.
All right, so good afternoon, everyone, or good morning, good evening, depending on the time you're watching this. I'm Anna Miller. I also work with menstrual health, menstrual education, so I'm so glad to be here today. So good afternoon, Dr. Lara. It's a pleasure to have you here. It's a pleasure to be here in this moment, and also to have your book in Portuguese. We are so happy about it because, as Isabel mentioned, it's a bestseller, and it's wonderful to have this book available for us in Portuguese. So we are so excited about this presentation. The microphone is yours, and let's start.
Okay. Hello, everyone, and thank you for inviting me to speak to you about the menstrual cycle. Oh, I need to share my slides. Yes.
Mm-hmm. And also, we're going to have like 45 minutes and then questions at the end. So everyone that sends questions, we're going to ask them at the end, okay?
Yes. So I'm happy to. We'll do at least 30 minutes of questions. And also you can, the slides that I'm showing can be available for everyone to have as a document, as a PDF. So if we don't get to every slide, then it's okay because you still have the information.
Nice. So, thank you so much.
Okay, so I think you already introduced me. I'm a naturopathic doctor. I'm Canadian, but I live in New Zealand. But today I'm in Canada, and I have a couple of books. And I'm also very pleased that my book is in Portuguese. So today we're going to begin by speaking about what is a healthy menstrual cycle. And of course, I'm talking about a natural menstrual cycle, not a pill bleed, because pill bleeds are not periods, and we will look at that. So the basic parameters of a healthy menstrual cycle are that the first day of the bleed should arrive every 21 up to 35 days. It does not have to be a 28-day cycle. Anywhere from 21 to 35 days is normal, or even as long as a bleed every 45 days for a teenager. Teenagers have longer cycles. Later in life, in our 40s, we typically have shorter cycles, as in the time between the bleeds. The other feature of a natural menstrual cycle, a healthy menstrual cycle, is the bleed should not last longer than 7 days. And you should not lose more than about 80 milliliters of blood or menstrual fluid. So that's 80. And that's equivalent to about 16 tampons over all the days of the bleed. One way to describe it I like is over all the days of the bleed, you should lose about the contents of one egg, like one chicken egg, about that much volume is a normal menstrual cycle. Of course, many women do lose more than 80 milliliters, of course, and heavy periods are a problem that we will try to talk about today. And finally, in my view, the period, the bleed, should just arrive with no pain or premenstrual symptoms. Of course, some pain and premenstrual symptoms are common, and having occasional symptoms is fine. It doesn't mean anything bad. But for most women, I think it is possible to get to the place where the period just arrives and you have no symptoms. So the reason for these parameters or these features of a menstrual cycle is this is what it looks like when you have a cycle in which ovulation occurred. So that brings us to a definition, which is the definition of a menstrual cycle. It's a series of hormonal events, including ovulation, and of course, the making of estradiol and our main estrogen and progesterone. So as you can see, ovulation is the main event of the menstrual cycle, not the period, not the bleed. And ovulation is not just for fertility or for making a baby. Of course, it's very important for fertility, but ovulation is also how, as women, we make the hormones we need for general health. So here, let's look at the hormones. I'm sure you've seen this before. This is a menstrual cycle. So across the bottom, we have days of the cycle, and then we have the two main hormones. So approximately 2 weeks before ovulation is the follicular phase, but that's the phase that can vary. So anywhere that can be quite short during perimenopause in our 40s, and it can be quite long in young women. In a teenager, the follicular phase can be 28 days long, and that's normal. And you can see estrogen in pink rising up to quite a high level just before ovulation. And then you see ovulation and then the rise of progesterone in blue, which, as I said, ovulation and the making of progesterone is the main event of the cycle. And then when we have progesterone, that is called the luteal phase. And the duration of the luteal phase should not vary. It is almost exactly 10 to 14 days long in a healthy cycle. So interestingly, this chart even is not to scale. So on some diagrams of this, you'll see estrogen and progesterone at the same level. That is not correct. This is a little bit more to scale, but actually in a true diagram, we make 100 times more progesterone than estrogen. So you could never have that on a chart because you wouldn't be able to see estrogen. It would be a flat line compared to progesterone, which is just quite interesting about how much progesterone we actually make. And then you can also see a little tiny blip of testosterone just before ovulation. So as women, we do make some testosterone. We only make a tiny amount compared to men. Obviously, men make 10 times more. But that little bit of testosterone that we do make, we can really feel it. And, oh, hang on. There we go. Yes. So thanks to pre-ovulation surge or increase in both estrogen and testosterone, women, according to scientists, women are stronger, more powerful, and resilient to stress during that time before ovulation. That's according to an Australian researcher. He says that women are almost superhuman at that time, which I love because I'm a huge fan of ovulation. So to say again, a natural menstrual cycle, including ovulation, is how we make these hormones, estradiol, progesterone, and testosterone. And estradiol is important, that's estrogen, is important for many aspects of health, especially metabolism or metabolic health. It improves what's called insulin sensitivity, so it helps to make the body better at turning food into energy. It reduces the risk of diabetes, for example. Estrogen is also anabolic, which means it builds muscle and bone. And progesterone also has many benefits. It's calming for both the nervous system and the immune system, which is why it's good for mood. And progesterone has natural anti-inflammatory benefits. And so finally, a small amount of testosterone is healthy for bones, muscle, mood, and motivation. Too much testosterone is not good for women, actually, and is a problem called polycystic ovary syndrome, which we will talk about today if we have time. For example, in women, too much testosterone can cause weight gain, especially weight gain around the middle, which you do see with polycystic ovary syndrome. All right, so that was a normal menstrual cycle, but unfortunately, you cannot, just because you're having periods, you cannot assume that you are ovulating, because it's fairly common to have what is called an anovulatory cycle, ciclo anovulatorio. It is the situation of a bleed, which can be regular or irregular, when you did not ovulate. So you can see there's lots of estrogen, but no ovulation, no luteal phase, no progesterone. It's not good. This is not a good situation. It is common. It's okay to occasionally sometimes have an anovulatory cycle, but to be healthy, most of us should be having mostly ovulatory cycles. Anovulatory cycles can occur with undereating, with polycystic ovary syndrome, and with perimenopause, perimenopause is anywhere up to 10 years before menopause, before the final period. And anovulatory cycles like this can also occur with progestin-only methods of birth control. So that would be like with the implant or the injection. The hormonal IUD or the hormonal like Mirena IUD is a little different in that it is also progestin only, but it can permit ovulation because the dose of the medication is lower. Now, the bleeds on the pill, the combined pill or the NuvaRing, I don't know if you have that there. It's similar to the pill. They induce, you can have bleeds on those, but they are not periods. They are pill bleeds. So they are withdrawal bleeds from the contraceptive drugs. So on combined hormonal contraception, like the pill, the ovaries are suppressed into a temporary menopause-like state. So the hormones are flatlined, as you can see here. There's suppressed estrogen, there's no progesterone. The contraceptive drugs themselves are present, of course, and they have hormone-like effects, but they're not estradiol or progesterone. So for example, if you were to do a blood test for estrogen and progesterone while on the pill, you would find none. It would look like menopause from a blood test perspective. And just to be clear, there's no medical reason to bleed monthly on the pill, right? Because if there's no ovulation, then the concept of monthly does not mean anything. The only reason we have a monthly cycle is because that's how long it takes to ovulate and then have a luteal phase. So of course, the pill cannot regulate the menstrual cycle because it's not a cycle. In fact, by masking or hiding an irregular cycle, by forcing a bleed, the pill can prevent diagnosis of what might be causing the irregular cycles. So we'll spend just 2 more slides on hormonal birth control, and then I'll try to get through some of the content around how to have a healthy natural menstrual cycle. Because of course, hormonal birth control or contraceptive drugs have their place. They are a way to avoid pregnancy, of course. They can also suppress menstrual symptoms. So some of my patients do take the pill, but again, they it's not an ideal situation because they can have side effects. So a lot of the side effects come from the fact that they're not hormones, they're different from hormones. So here we can see on the left is a medication called levonorgestrel. It's a progestin. It's in the hormonal IUD, it's in some of the implants, it's in a lot of the pills. It's sometimes called progesterone, but it's not. You can see progesterone on the right is real progesterone. Hopefully you can see it under the video. And this difference in structure can lead to differences in the body. For example, real progesterone stimulates healthy hair, which is why women, when they're pregnant, have so much hair. Whereas levonorgestrel, the one I just showed you, that medication can cause hair loss primarily because that medication that I just showed you is actually more similar to testosterone than it is to progesterone. So it can cause hair loss. Another example is that progesterone, real progesterone, is usually good for mood and sleep, but some progestins, especially drospirenone, I can put that in the comments later, can cause anxiety and depression. That's a particular progestin. It's the one in Yasmin has the strongest link with mood symptoms. Then there can be digestive problems, low libido, impaired bone health. And the last point there is a delay in maturing the menstrual cycle. So that's about how the fact that in a girl, it normally takes about 12 years to fully mature the menstrual cycle. So from when a girl gets her period at maybe age 13 to when she's having regular, robust menstrual cycles at age 25, and by 25, she should be making lots of progesterone. So if you put a girl on the pill when she's young and switches off that maturation process, then you cannot reasonably expect for the period to be just instantly regular upon stopping the pill, if that makes sense, because the hormonal system has been suppressed, possibly for years, and it can take a while to get going. Right, so how's everyone doing? Anna, everybody okay? Yep. Okay. This is what I'm going to try to, yep, we're all good. Okay. This is what we're going to try to cover in the next half an hour. Yeah, about 30 more minutes, and then I'll stop for questions. So we're going to look at lack of periods or irregular periods and the difference between polycystic ovary syndrome and undereating. And then we'll look at pain, heavy flow, and premenstrual symptoms. Understanding that there is no one size fits all. I don't know how well that translates into Portuguese, but there's no one treatment for everybody. So we have to keep that in mind. So starting with lack of periods or irregular periods, which is, of course, I'm sure you can understand, is because of a lack of regular ovulation. So the goal is to ovulate. But how do you do that? Well, again, there's not one way to achieve ovulation, not one diet or supplement or medicine that will guarantee ovulation in everyone. Instead, there are what I call obstacles to ovulation. So there's many different possible obstacles to ovulation that the doctor should be thinking about, and not just giving the pill to force a pill bleed, because that's not a menstrual cycle. But all the obstacles to ovulation fall into 3 categories of problems, essentially. So one is nutritional deficiency. So if there is not enough food or not enough nutrition, that can stop ovulation. So not having enough calories simply can stop ovulation, not having enough protein, not having enough zinc. Zinc deficiency is a common cause of lack of ovulation. The next category is any kind of illness, inflammation, or other dysfunction. As I say in my book, fix your health and you'll fix your period very often, because the period, the menstrual cycle, is a reflection of health. It tells the story of health. So if there's anything going on, like thyroid disease, for example, or insulin resistance, which is a pre-diabetes, which is common, that can stop periods or cause irregular periods. Gluten sensitivity or celiac disease can definitely stop periods. In fact, every woman with irregular periods is supposed to be screened for celiac disease or gluten sensitivity. That doesn't always happen, but. And then, of course, there are lots of medications that can impair or prevent ovulation. So obviously, hormonal birth control does that because it's designed to do that, but also corticosteroids, certain types of antidepressants. There's a medication called spironolactone. I don't know how the translator is doing with these terms. It's okay. I can.
It's the same name in Portuguese.
Is it?
That one.
Yeah, yeah. That can stop ovulation. Great. Okay. All right. So if you have been without a period for more than 3 months, or have had irregular periods for 6 months, you should see your doctor, who, as I say, I hope will become a detective and try to figure out why you're not having periods, and not just give the pill, because that doesn't fix anything. And of course, in my book, I talk about some of the reasons. I give some patient stories. There are lots of different reasons, but at the end of the day, the two most common, not the only explanations, but the two most common explanations for no periods or irregular periods in a young woman is either polycystic ovary syndrome, which is the condition, or hypothalamic amenorrhea. So polycystic ovary syndrome is the condition of androgen excess or testosterone excess and possible anovulation when all other causes of androgen excess have been ruled out. It's important part of the diagnostic process, because there are other reasons for high androgens or testosterone. In contrast, hypothalamic amenorrhea is a lack of periods or irregular periods caused by undereating. Quite common, actually, becoming more common because young women, maybe even more so than before, are restricting their diets, and it can be a big problem for periods. So these are obviously two very different conditions, but unfortunately, hypothalamic amenorrhea, undereating, is frequently misdiagnosed as PCOS or as polycystic ovary syndrome, which is a problem because the main treatment for undereating or hypothalamic amenorrhea is to eat a lot more, whereas the main treatment for polycystic ovary syndrome is possibly to eat less or to eat fewer carbohydrates, for example. And eating fewer carbohydrates is the wrong treatment for hypothalamic amenorrhea. So it's very important to get the right diagnosis. So I'm going to do a little compare and contrast. Don't worry, some of this is a little more technical, but mostly it's, I'll explain where I need to. But both the conditions are the situation of no periods or irregular periods. And then going down the list, polycystic ovary syndrome, by definition, has high testosterone symptoms. So facial hair, that's called hirsutism, or strong acne on the jawline. Whereas in contrast, hypothalamic amenorrhea usually does not have androgen symptoms, unless a woman is trying to come off a pill like Yasmin, and in which case there can be post-pill acne with hypothalamic amenorrhea, which is a little hard to figure out sometimes. But polycystic ovary syndrome often, not always, but often has insulin resistance, which is prediabetes. I spoke about that already. I'm writing my third book, which is all about insulin resistance or prediabetes. So that will come out next year. Hypothalamic amenorrhea, it has normal fasting insulin level. So the next line in the chart is if for someone, if they've stopped the pill, and so when you stop the pill, you stop having pill bleeds or forced withdrawal bleeds. And then in the case of PCOS or polycystic ovary syndrome, there can often be a few periods, real periods, upon first stopping the pill, but then they become irregular. Whereas with hypothalamic amenorrhea, there's usually nothing, just totally no period at all, nothing happening after stopping the pill. The next couple lines, I won't sort of go too much into. The next one is about testing two hormones called LH and FSH. I don't know if they're the same in Portuguese, but you can sometimes use those to try to see, because with undereating, LH, that hormone will be quite low, be quite suppressed, quite low compared to FSH, whereas it's the opposite with PCOS. So one thing I want to say about a symptom that is not on this list, which is pain. Pain is not a symptom of either polycystic ovary syndrome or hypothalamic amenorrhea. So if pain is the main symptom, there's something else going on, like endometriosis, which we'll come to. Even if you were told you have polycystic ovary syndrome, there's a lot of misdiagnosis happening with polycystic ovary syndrome. And it's all because of polycystic ovaries on ultrasound. So you see the next line, both of these conditions can have what are called polycystic ovaries on an ultrasound study. You can have it, as I said, with endometriosis, anyone can have polycystic ovaries on an ultrasound study. It doesn't really mean anything, which is this next slide. So polycystic ovary syndrome, the condition, the hormonal condition, cannot be diagnosed or ruled out by an ultrasound. And that's because the polycystic ovaries are not cysts. Instead, they are follicles or eggs, which are normal for the ovary. So that's different from an ovarian cyst, which can happen. There are lots of different kinds of ovarian cysts. Those are a different situation. If you want more about this, I have a YouTube video about polycystic ovaries and ultrasound and the confusion. And I think on YouTube, you can just click, you can choose the auto-generated subtitles. So you might be able to get that in Portuguese. Okay, so a little bit on treatment. Oh, yes, we have time. It's good. We're just on the hour. So for treatment, the main treatment for hypothalamic amenorrhea or undereating is obviously to eat more, much more, way more. I think much more than women even expect. I think a message to some young women would be that you need a lot more food than you think, especially if you're active and doing exercise. Evidence-based treatments for PCOS, for polycystic ovary syndrome, include, yes, diet and exercise, which can be helpful. That usually means lower sugar, less sugar. It could be lower carbohydrate. There could be what's called intermittent fasting that can be helpful. We can talk about that in the questions. As long as you've got the diagnosis right, and it truly is insulin resistance and polycystic ovary syndrome. Next, there's a supplement, which I hope you can access there. It's called myo-inositol or just inositol. And it works very well for polycystic ovary syndrome. It lowers testosterone and it promotes ovulation. And it's so effective that it made it into the international evidence-based guidelines for polycystic ovary syndrome, which is really amazing for a supplement. The next one down is zinc, which has been clinically trialed for acne. It has not yet been trialed or proven to work for polycystic ovary syndrome, but I prescribe it all the time. It does work by lowering androgens. It also has a natural antibiotic effect on the skin. And one thing about zinc, this might be helpful, if anyone who's trying to follow a plant-based or a vegan diet needs a zinc supplement, because there's very little zinc in plant foods. Most zinc comes from meat. And Zinc's usually fairly inexpensive, easy supplement to access. The one thing to know about it is you should definitely take it with food, because zinc on an empty stomach can make you feel sick. And finally, this last one, it's called cyclic progesterone therapy, and it uses real progesterone, what's called body identical progesterone. So not the pill, not progestin, but real progesterone, 2 weeks on, 2 weeks off. And I wrote a scientific paper about this with my colleague, professor in Canada, about using so-called natural progesterone for PCOS. So I don't know in Brazil if it's available, or if anyone knows, they can chime in. In America, it's the brand name is Prometrium. In some countries, it's available as Utrogestin. I'm guessing it's probably Utrogestin there. Does anybody know?
I'm not sure about the name of it,
The brand name. Yeah,
I'm sure it's available.
Yeah.
As from my experience, it's not so common. Yeah, that's what they said. Utrogestin.
Utrogestin. Yeah. Okay. Good. All right. Good. So we have time. Let's move on to painful and or heavy periods. Obviously, painful and heavy are they're different things. They can sometimes happen together. So the most important thing is to try to get a diagnosis. And there are many possibilities, including a condition called adenomyosis. You may have heard of that. I talk about it in my books. Endometriosis, which I'm sure you've heard of, is quite common. It affects 1 in 10 women, and both of those conditions can cause quite severe pain. Then, of course, fibroids can cause pain or bleeding. And then next on the list is anovulatory cycles, which I talked about earlier, which, remember, are cycles when you did not ovulate. So you didn't make progesterone, which normally makes the period lighter. So not having progesterone can cause long bleeding, like bleeding for like 10 days, or heavier bleeding. And then going down the list, there's also coagulation disorders. I mean, this would be up to the doctor to try to figure this out about it. What the statistic is for women with very heavy bleeding, if they've had it all their life, there's about a 1 in 5 chance it's a genetic coagulation or bleeding disorder. So that's just something to hopefully get diagnosed. Underactive thyroid or thyroid disease can cause heavy bleeding. Pelvic floor dysfunction can cause pain. It's quite a common cause of pain, actually. And in that case, you might need a physiotherapist who works with the pelvic floor. And then pelvic inflammatory disease, that's an infection. So obviously, yes, if there's pain, the doctor needs to figure out why there's pain, and then, as much as possible, treat the cause of the pain. So I've already mentioned, if the pain is from the pelvic floor, then you could get physical treatment for that. If it's the pain's from an infection, of course, you'd need antibiotics. There are lots of natural treatments for all of these conditions. I will say a little bit more about endometriosis because it is so common, and also because it usually needs more treatment than the basic plan that I'm going to provide. So in a couple of slides, I'm going to give some basic strategies for pain and bleeding, but endometriosis almost always needs more. So endometriosis is an inflammatory disease in which tissue that is similar to the uterine lining grows in other places other than inside the uterus where it's supposed to be, and can cause pain. And it's important when you're thinking about pain, how much of pain is normal. So really, in my view, no amount of pain is normal. But that said, there is a certain amount of pain that even I have had at times with the period. So I guess we define it this way: normal period pain is quite mild cramping, and it occurs during the first first or second day of the flow. And it improves with painkillers, so ibuprofen. And it doesn't interfere with your day. So with normal period pain, you can still go to work, you can, do sport, it's not a problem. Severe period pain is quite different, and it's not just cramping, it's throbbing or burning or stabbing. And it can occur not just during the flow, but even between periods, and the painkillers do not help it. And it might be so bad that you miss school or work. And so it's very important to know that debilitating pain is never normal, never normal. And it could be endometriosis, or it could be some of those other conditions. So everyone is waiting for endometriosis for a non-invasive diagnostic tool, because as you may know, at the moment, it sometimes requires surgery to diagnose, but scientists are working on a variety of different options, and there's a special kind of ultrasound you can have that can sometimes pick up endometriosis, detect endometriosis. But please know that having a normal ultrasound does not rule out endometriosis. It doesn't go in the other direction. You can sometimes see it on ultrasound, but even if you don't see it, it could still be there. So my approach is usually with my patients to start with the basic strategies, which I'll show you in a couple of slides. And then if that doesn't eliminate period pain, then try to get a diagnosis and then look at some of the natural treatments of endometriosis. So I don't have time to go into those today, but this is another episode of my podcast, which, as I said, is available on YouTube. So I do hope that if you select the subtitles, you can hear, this is a 15-minute explanation of immune treatment for endometriosis, natural immune treatment. Okay, so that brings us to what I said. These are more just like general treatments for heavy or painful periods that should be in addition to treating the cause, hopefully. So the first one is zinc. I keep mentioning zinc. I do love it. It did undergo a study, a clinical trial, in which it was found to be as effective as the pill for period pain, which is amazing. And then the next line down, this is more for heavy periods. So with heavy periods, it's really important to correct an iron deficiency, because heavy periods cause iron deficiency, and iron deficiency is quite bad. It's bad for immune system, it's bad for mood. But also, having an iron deficiency can make periods heavier, so it can become a vicious cycle. Going down, the next simple strategy of avoiding or reducing normal cow's dairy. Now, I do talk about this in my books, and I'm curious because I don't know in Brazil what kind of cows you have there. In America, in the US and Canada and Australia and New Zealand, we have cows that make quite an inflammatory protein called A1 casein, and that can cause period problems. Whereas like in these countries, if you can choose dairy that's from either goats or sheep or Jersey cows, that in that case, the milk is not inflammatory. So I'm curious, I'm trying to take an informal survey of which countries have the inflammatory kind of milk or not. If anyone knows, they can let me know.
So one of the girls said that one of our brands here in Brazil already has A2 milk, but mostly you have the A1.
The normal, yeah. So, and again, not every person is sensitive to A1 casein, but for women who react to it, get an immune system, a negative immune system, inflammatory reaction to that A1 casein, one of the symptoms of that can be painful heavy periods. So it's quite a simple thing to try, usually for 2 or 3 cycles, just to see if that makes a difference. Great. Okay. And then anti-inflammatories, so curcumin or ibuprofen can both lighten the flow. One thing, so curcumin or turmeric, I'm not sure how easy that is to act, because I'm talking mainly about like as a supplement. Of course, you could also use the spice. One thing to know about curcumin, though, is it does block or impair iron absorption. So if you do take curcumin, you want to take it separate, like a few hours apart from your iron. Okay, and then next on the list is progesterone. We talked about this before with the cyclic progesterone therapy. This is the natural progesterone. I think it's Utrogestin in Brazil. It can lighten flow. And of course, progestins, as in the hormonal IUD, they also lighten flow. But the point is progesterone can also do that with fewer side effects. All right, so we've just got about 5 more minutes. It's perfect. I'm going to talk you through premenstrual mood symptoms, which can be quite mild, or if they're more severe, then it would be something called premenstrual dysphoric disorder in English, or PMDD. So both of these conditions, whether it's the mild or the severe, can respond to some of the same natural treatments. But if for women with PMDD, I don't know how common a diagnosis it is there, but probably should also be under the care of a psychiatrist. It can be quite severe for some cases. So, all right, so by definition, premenstrual mood symptoms are symptoms that occur during the luteal phase of a natural ovulatory cycle. So mood symptoms that occur after the period are something else. They're usually from low iron. And mood symptoms on the pill or on any type of hormonal birth control are side effects of the contraceptive drugs. They're not premenstrual symptoms. They're drug side effects. And finally, on the hormonal IUD, it could be both. It could be side effects of the levonorgestrel, the progestin that's in the hormonal IUD, or on the hormonal IUD, because it is possible to ovulate on the hormonal IUD, you could be having true premenstrual symptoms, or both. So again, with premenstrual mood, there's, again, no one size fits all. There's lots of different things going on because there's different variables in premenstrual mood symptoms. So starting on the top left, this is all about histamine, which is a type of inflammation. And histamine is involved in allergies, but it's also a neurotransmitter. So histamine is quite irritating. It can create sort of anxiety and irritation. And histamine tends to track or go up with estrogen because estrogen stimulates a histamine release, and also histamine can stimulate estrogen. So it can be a vicious cycle. So this would be, for example, people might feel they have symptoms not just premenstrually, but right around the time of ovulation. And they might also get like nasal, like allergies or rash or fluid retention, joint pain, even nausea, breast pain. These are all symptoms of high histamine, and migraines as well. And premenstrual migraines is another common symptom that we don't have time to go into. But so this role of histamine is why premenstrual mood symptoms can be relieved by antihistamines. In fact, antihistamine medication used to be prescribed quite often for premenstrual mood, and then it fell out of fashion for some reason. But it can be a good test just to see if your symptoms respond to over-the-counter medicine, antihistamine, and then you can also look at some of the natural antihistamine strategies, which would primarily be a dairy-free diet, avoiding the A1 casein, like we talked about before. I talk about some other natural antihistamine strategies in my book. So then, and also reducing histamine can also lighten periods, because histamine tends, the mast cell or that part of the immune system activation tends to make periods heavier. Hope that's clear. All right. Next, iodine deficiency can play a role in premenstrual mood symptoms. again, that might be the case if there's quite strong breast pain or breast tenderness, which can be a sign of iodine deficiency. I talk about iodine quite a lot in my books and on my blog. You do have to be careful with it because too much iodine can harm the thyroid. And so I would encourage you to read those sections, or maybe we'll talk about it in the comments. It's worth considering as a treatment, but you just need to be a little careful. Then magnesium is very soothing, very calming. Magnesium is very safe to take. You can take it on its own, or you can combine it with an amino acid called taurine and maybe something called vitamin B6 that can all be quite calming for premenstrual mood symptoms. Vitamin B6 is the other nutrient that you have to be a little bit careful with. You don't really want to take more than about 50 milligrams of B6. All right, and then there are lots of other factors which I've listed here. You can have borderline high levels of a hormone called prolactin, and that's when you might want to use a very popular herbal medicine called chaste tree or vitex. There can be an abnormal sensitivity to progesterone. So for most women, progesterone is very calming and soothing, but some women get an anxiety reaction from even their own progesterone. But that's unusual. For most women, the premenstrual mood symptoms are not from progesterone, but rather from withdrawal from progesterone at the end of the cycle. And then lots of things like treating the gut microbiome, spending time outside can be really good for the brain. And so as with everything, it can require a little bit of detective work, but it's worth it because premenstrual mood symptoms can dramatically improve. It's my favorite thing to treat because then my patients will say, oh my goodness, I just had a period that just arrives with no food cravings, no headaches, no irritability. All right, I'm just gonna take you through a few messages, takeaway messages, and then we'll do some questions. So first, ovulation is how women make hormones, which means a regular natural menstrual cycle is important for general health and not just to make a baby. Pill bleeds are not menstrual cycles, as we've seen. And finally, trust the body. I like to finish all presentations with this slide because, yeah, the body knows what to do. Women's health is not as mysterious or complicated as we've been led to believe. All right, thank you very much.
Thank
I'll stop sharing.
you.
Yeah.
So nice, so amazing. And your book is awesome. So for the ones who have not read it yet, I'm sure this was a very nice introduction. What?
Sorry, I'm sorry.
I'm
just I'm still here. I'm just trying to change my computer over. Sorry about that. I'll come back.
No, that's okay.
I'm back.
All right. So thank you very much. I'll go with some questions. I'll start with one that 2 women sent us. So how is this relationship between inflammatory disease, pelvic inflammatory disease, and heavy periods? So 2 people asked us about it.
Yeah, so pelvic inflammatory disease is an infection in the pelvis. So it's usually pretty easy to treat with antibiotics, but it can cause pain. I believe it can make the periods heavier. It depends. It won't always make periods heavier, but there might be fever. And it's definitely the kind of thing that should just be treated with antibiotics and not deal with that on an ongoing basis.
So basically it's because of the inflammation, the relationship.
Yeah, correct. Yeah.
All right, nice. So our next question would be, could you tell us a little about the repercussion of your books in other countries and how different cultures receive the information you bring?
Yeah, well, it's been very positive. It's interesting because maybe even 7 years ago when I released my first book, it was controversial to talk about the pill in this way and to criticize it, but that has changed. It has definitely become more common for people to acknowledge that suppressing the female hormonal system with medication for years is not good for women. I just spoke to a doctor this morning who understands that. So I think we're approaching a time when everybody is very ready for a change. And yeah, I have not had as much pushback as I expected. I've had a lot more excitement about the fact that you can treat the period in other ways. You don't need the pill for every single symptom.
Yeah, hopefully, because in Brazil, we still see a lot of strong medication, and the pill is basically the, let's say, savior of all menstrual symptoms, which of course we know it's not true, but we still see many doctors say that. So it's nice to hear that you're having this kind of success, because that's what we are waiting for here in Brazil.
How popular is the hormonal IUD there? Because it is better in that it does permit ovulation, it does permit cycling. It is still the medication that can have side effects, but it's better. And so I don't know if that's changed. I think that's baby steps. Like that's a beginning to use the IUD instead of the pill.
Yeah, we've seen some expansion of the use, but still the pill is the most used.
Yeah.
Unfortunately, but I agree with you. Baby steps, we're getting there.
Baby steps, yeah.
Yeah, okay. Some people, some women are asking us about perimenopause. So a little about the treatment, how long does supplementation usually last? If you agree that all women should, and I believe not, but all women should have this kind of treatment. So can you tell us about it a little bit?
Well, you'll have to have me back next year. My second book is about perimenopause, and I have a presentation like this about perimenopause. So we might need to wait for that. But what I will say is, not every woman requires hormone therapy. I know that is a narrative that is happening right now, but that is incorrect. Menopause is a natural life phase. Some women do benefit from hormone therapy, of course. So I talk about that in the book, but some women don't need it, and they shouldn't have it. They shouldn't be made to feel afraid if they're healthy in other ways. So perimenopause is, as I said, about 10, it's not always 10 years, sometimes less, but up to 10 years before the final period. And most of the symptoms are either heavy periods or neurological symptoms like migraines or night sweats, or not sleeping is a very common problem. And as you can imagine, those symptoms respond very well to natural treatment. So they do respond incredibly well to magnesium. They respond to quitting alcohol. I always have to mention that. I would say with my patients, if they just stop drinking, even if it's only moderate drinking, and they stop it, 50% of the time, that's all they need to do. The symptoms go away. But then you can also look at using, some other supplements. You can look at using progesterone, the butrogestin that we talked about, on its own, or with a little bit of estrogen. Lots of options. Yeah.
Okay. And there is a question here that we know, and I could say that's a big problem here in Brazil, because someone mentioned that the question actually is there an ideal value for progesterone dosage? Which we know the answer is no, right? Because she said that right after ovulation, she starts having spotting for like 15 days. Okay. And all the doctors say that since her exams are normal, this is just how her cycle is. And this is something that happens a lot here in Brazil, and I'm not sure if that happens a lot around the world as well. But here, unfortunately, when we have normal range of hormones, doctors would just say, "Oh yeah, that's the way it is." So, what can you tell us about it?
Yeah. Well, there can be different. Again, it would be to try to find the reason. I mean, I cannot comment specifically on that person but like one positive, just as an example, having underactive thyroid is a reason for spotting. So there can be obviously things going on with the uterine lining. There could be lots of different explanations. Presumably the doctors looked at that, but gluten can be another reason for that. So a gluten sensitivity. But in terms of a dose of progesterone with the oral, with the Utrogestin, it's usually anywhere between 100. So one capsule is usually 100 milligrams. So it's between 100 and 300 milligrams at bedtime. You always take it at bedtime because it's very sedating. And that can sometimes help with, bleeding symptoms, especially it depends on the age of the woman too. So in our 40s, unusual bleeding can become quite common and a problem. And that's usually when something like Utrogestin or progesterone might be required. With younger women, especially with teenagers, I prefer to try to get their own body to fix the problem, to make their own progesterone. And that's young women do not usually require progesterone therapy, although the exception might be with polycystic ovary syndrome. Sometimes cyclic progesterone can be helpful. It's certainly better than the pill, I think, for young women. So, yeah.
And that's actually one more question about that. So for women with low progesterone, in addition to Vitex, you also mentioned cyclic progesterone, right? So changing lifestyle and diet, what do you usually believe that they're, sorry?
Progesterone it's the final reward for everything that went right with health. Like, so if progesterone is low, there's an obstacle to ovulation. I mean, ovulation is still happening, but that obstacle to ovulation that I talked about, that can also show up as low progesterone, not just no progesterone or low progesterone. So for example, if there's a thyroid problem, if there's a gluten problem, if there's PCOS, if there's like stress, illness, anything like that, any nutrient deficiency can cause low progesterone, right? So there's not one, it's about being a detective and thinking, why am I not ovulating as strongly as I should be? And also age is a factor. Obviously in our 40s, we can't make very much progesterone at all. That's just a fact. But for a young woman, it's usually about fixing what's going on with her and then you get progesterone as the reward. Yeah.
Nice. So it's,
you need to go upstream.
Detective work is very important.
Yeah.
Yes.
Yeah.
No, that's true. There are studies about the 100 days necessary for the process of maturing the follicle. So a woman said that we have these studies. Can you talk more about this? What studies address this issue, and how can our practices or lifestyle influence this maturation process?
Yeah, well, that relates to what we were just talking about in terms of making progesterone from a healthy ovulation. In my book, talk about the 100 days to ovulation. So those eggs or follicles that are eventually will ovulate and make progesterone, that starts months ago. So the way that comes into practice is it's a long-term plan. Like in English, we say you need to play the long game. I don't know how that translates, but you don't just do something and expect, oh, my period will be fine this month. Like for example, if you lost a girl who lost her period to under eating, would have to start eating a lot like 2,500 calories at least per day for months. And then at some point, she will get the reward of ovulation. Likewise, for any of the PCOS treatments, any of the conditions that involve ovulation problem, you have to allow time, like at least 3 months, usually 4 or 5 or 6 months, to see the effect, to see the change on ovulation, because the treatments are working on those little baby ovarian follicles for all the 100 days that they're ovulating, if that makes sense.
And this is so important, right? Because we are so used to waiting for change like in 2 weeks or let's say
exactly.
one
We want instant results. Yeah.
So Anna, you said you want to ask a question directly, so feel free.
Thank you. Hi, this is another Anna Silva. First of all, I'd like to say how much I appreciate your work, because it has become like a foundation, my studies, to become a woman, like to work with women's health as a therapist. So, because the way you explain and share knowledge is very like easy to understand. So that's my point. So thank you.
Yeah. Thank you.
And my question is, I would like to hear, what do you know about seed cycling for hormones balance? Like phase 1, we like eat sesame and pumpkin seeds, and then flax seed and pumpkin seeds, and then the next one would be sunflower seeds and sesame.
Yes. So this is a question about seed cycling. It's very popular, especially in Canada and the US and Australia. Very popular. My short answer is I don't know. I've never used it as a doctor. I think one thing to say is that seeds generally are quite healthy. It's what makes sense to me, that putting seeds in the diet is going to be beneficial for hormones. As to whether, I don't know. I mean, because there is something to be said for sort of doing anything 2 weeks on, 2 weeks off potentially could help promote a cycle, but it's a good question. I get asked it a lot and I never know what to say, because there's no science in it, and I cannot say for sure that it works, but I know a lot of women love doing it, and there's no harm in it because it's seeds and they're good for you. So that's
because our group got very interested about studying like this cycling. So there's not much study about it. That's the point.
There's no, to my knowledge, there's no science around it, but that said, seeds are nutritious, and the phytoestrogen part of them is quite good for women's hormones. So,
Thank you.
Yeah, good question. Thank you.
All right, nice. You mentioned something about intermittent fasting for PCOS. Could you tell us about?
Yeah, for sure. Well, this is about, does everyone know what I mean by insulin resistance? That's in my book, and it's pre-diabetes.
I think so.
So as I said, my third book is about insulin resistance. So that would be for anyone with polycystic ovary syndrome, for a lot of women in perimenopause deal with insulin resistance. One strategy can be some gentle intermittent fasting, or more likely what happens for women is what's called time restricted eating. So it's not complicated. It's really just like stopping, having your evening meal by like 7 p.m. and then fasting overnight, basically fasting until maybe like 8 or 9 a.m. breakfast. So you can adjust the timing of that too, but it's just giving your body the gift of, some hours, especially the overnight hours of fasting, like gentle fasting. And it can help to improve insulin sensitivity. It's quite a controversial topic, because the problem is what happens is anytime something like this gets discussed and possible benefits, then, for example, we might have young women who are already restricting their eating, like doing it more. And so that's not good. And certainly any women who are very active in sport need to be careful, because it is important to eat enough as well. So I hope I've explained that properly. It is for someone with demonstrated insulin resistance or pre-diabetes, or that weight gain around the middle. It's one of several strategies that can help. And it's certainly easy, because it's just involves simple fasting overnight. So yeah.
But diagnosis is very important.
Yeah,
We have to stress that. Okay.
And you don't want to, and again, this is it's important to not restrict food more than you need to, because women do need food. So
So for women who don't know that they ovulate, so they don't do, well, this kind of following in their cycles, how to know the day to collect progesterone for blood test? Can a fixed progesterone test done on day 21 of the cycle be considered? Is it the best time?
no, day 21 is not helpful, because imagine, like I said, you can have up to a young woman, a teenager could have a 45-day cycle. So on day 21, she's still follicular phase at that point, right? So there's no progesterone yet. So I do have a blog post in English. It's called The Right Way to Test Progesterone. I know some of my blog posts have been translated, so maybe that one has been. There's two ways to do it. You can either track ovulation with temperatures and then measure your progesterone, 5 to 7 days after your temperatures go up. That's peak progesterone. But to be honest, if you're tracking temperatures, you probably don't need to test progesterone, because you know for certain that you're making progesterone because of the temperature rise. But the other way is, if the cycle is regular, plan to have the blood test 7 days before the next period is due, right? So then you're timing it more with the end of the cycle, which is the predicted end of the cycle. So if you normally have a 35-day cycle, then you would want to be testing progesterone on around day 28. But you then have to make sure the period came when you expected it. You can only interpret the progesterone reading, once you know if you were mid-luteal, right? Like if you were within 7 days of your period. Does that make sense to everyone? Hopefully.
Yeah. For sure.
Yeah.
Okay. Someone asked about low progesterone and testosterone at the same time. What about it? This person asked, but I would say it can be common as well, or no? I think that's the question.
Yeah, the low testosterone, there's a lot. Testosterone is kind of a complicated. I would find low testosterone is not that common. Actually, low progesterone is extremely common, because it's quite difficult to ovulate. And low testosterone has to always be interpreted. I guess you have to look at something called SHBG that comes through in translation to know.
I think it's the same thing. Yeah, as we say.
SHBG is the same. Yeah. So, for example, a very common cause of low testosterone, obviously, is the pill, because it suppresses hormones, all hormones, including testosterone, and also being on the pill, and especially even being off, like recently off the pill, even for a couple of years, SHBG can be quite high, and that's a protein that binds up all the testosterone and kind of robs you of testosterone. So that might be one scenario of low testosterone. But if I'm honest with my patients, it's usually more a problem of high testosterone. So you get kind of high testosterone with polycystic ovary syndrome, with perimenopause sometimes. People actually, for what it's worth, in the science, the people who tend to have kind of low testosterone are women with endometriosis. It does tend to be sort of a genetic lower testosterone aspect to that. So they used to give testosterone for endometriosis, actually, but they don't do that anymore because it has facial hair and too many side effects. But yeah, and then there's the whole, like, what the adrenal glands are doing, because they're an important source of something called DHEA, which is an androgen, or like a cousin to testosterone, that can be important later in life. So hopefully that answers the question. Yeah.
A lot of investigation, I suppose, is needed as.
Yeah. Mm-hmm.
So to finish, just
Okay.
one more question, since
Yeah,
we're
great.
gonna finish in 1 minute. So can psychiatric medication disrupt progesterone production?
Oh yeah. Oh, definitely. Yes, certain psychiatric medications, certain types of antidepressants, and other, antipsychotics and that type of thing can definitely suppress ovulation. That would be in the category of medication-induced period problems. So, yeah, that's hopefully, again, that requires some detective work. Figure out if there's an alternative. The other one that does also seem to disrupt ovulation and periods is Adderall or Ritalin. I don't know what it's like down there. A lot of people now are getting the diagnosis of ADHD and being given amphetamine. It's a whole other topic, but yeah, that does seem to, I've had patients who are on that and their periods go weird. So if your period has gone very strange when you started a new medication, the first thing to think about is, was it that medication? Yeah.
All right, so we'll stop from here. We have like some questions, but Isabel told me that she will send them by email to you.
Okay.
So I would like to thank you very, very, very much. This talk was very special to us. As we mentioned, we're so happy to have your book in Portuguese and can't wait to have the other books in Portuguese as well. So I hope Isabel is already thinking about it, because we are definitely thinking about it. We would love to have all your books, and it was so exciting, so important for us to have you here. So thank you so much, Lara.
Oh, thanks for inviting me and for being such a great audience, and thanks, Anna, for your help with the the conversation. And I hope all the translation came through. I'm impressed that the translation was able to happen simultaneously. So
yeah, she's very good. So
and
thank you, Fernanda, as well.
Fernanda, yes, amazing. Thank you so much. Okay. All right, everyone. Well, have a good evening. And I will see you next time.
See you. Thank you very much. Good evening. Bye-bye.